Okay, now for the last part, and I am going to help you guys focus. I'm gonna write something up and post it in an announcement to help you um, focus your studies because I know this is a lot of information, and I feel that you are getting overwhelmed. I'm just guessing, but I think it's a pretty good guess. So I'm going to finish covering these last few slides and then I will write something up for you guys because I know two of you are taking it early in the testing center and don't have as much time to study. So we're picking up with rotavirus. Rotavirus, when you think of that, you think of diarrhea. It can also have vomiting, but the diarrhea can be so bad and so watery that it results in severe dehydration in babies. It is usually accompanied by fever and abdominal pain, but the main thing is dehydration. Rotavirus was the leading cause of severe diarrhea among infants and children in the United States before the rotavirus vaccine was introduced in 2006. So we've had a vaccine for rotavirus since 2006. Prior to that vaccine, almost all kids in our country were infected with rotavirus before their fifth birthday. And each year of kids less than 5 in our country, rotavirus led to more than 400,000 doctor visits, more than 200,000 emergency room visits, 55 to 70,000 hospitalizations, and 20 to 60 deaths from diarrhea. Globally, rotavirus is still the leading cause of severe diarrhea in infants and young children. In 2013, rotavirus caused an estimated 215,000 deaths worldwide in children younger than 5. So in our country, we have 20 to 60 deaths per year due to rotavirus. Worldwide, in 2013, there were 215,000 deaths in children younger than 5. And that is just a crying shame. So here we can see rotavirus deaths in children under 5. The red is greater than 100 deaths per 100,000 people. And the pink, such as in South America and parts of Asia and the Middle East. And in Northern Africa, we have 20 to 100 deaths per 100,000. So this is very serious um, still today. So this is what our vaccine looks like. Rotarix. Each year, the vaccine prevents an estimated 40 to 50,000 hospitalizations among United States infants and children. The hospitalization is solely for the purpose of rehydration. The rotavirus illness has also decreased among older children and adults that are not vaccinated. So the vaccinated children are providing indirect protection to other people because they're less likely to contract and spread the disease. All right, the next thing is chickenpox, varicella, airborne, contact, and droplet. It's caused by the varicella zoster virus, which is a DNA virus that is a member of the herpes virus group. After the primary infection with varicella, the virus stays in the body in our nerve ganglia as a latent infection. So the first time you get infected with the varicella zoster virus, you get chickenpox. That's your primary infection. If the infection that is latent is reactivated later in life, then it causes herpes zoster, otherwise known as shingles, which is very painful and is found along the nerves because that's where the virus is dormant. Varicella is highly contagious. It can be spread from person to person by direct contact, inhalation of aerosols, um, the fluid from the lesions, possibly respiratory secretions that are aerosolized. A person with varicella is contagious beginning 1 to 2 days before the rash appears, and they remain contagious until all the lesions have crusted. These people are considered contagious until no new lesions have appeared for 24 hours. So, based on studies of transmission among household members, about 90% of susceptible close contacts will get chickenpox once they're exposed to a person with disease. So, that is significant. We hardly ever see chickenpox anymore in the young children because of the varicella vaccine. Clinical presentation, fever, malaise, just general tiredness, doesn't feel good, coryza, the rash first on the trunk and the face, and then it spreads outward, severe itching. Our vaccine is the Varivax vaccine. We've had this since 1995. And with Varivax, the child must be at least 12 months old to receive the chickenpox vaccine. We have to be 12 months old. These are cases of chickenpox from 1997 to 2016 in Louisiana. You can see we had a spike in 2004, but overall, since 1997, it declined, had a sharp spike, and then it's really kind of hanging out right here, isn't it? So it's still present, but I mean, look, rates per 100,000 of population in 2016, we had about 2 cases for every 100,000 people. This is a picture of a full-blown case of chickenpox. If you are too young to have ever had chickenpox, I remember this well. Many of us still have the scars. And then this is a case of what they call breakthrough varicella, where the child was vaccinated and they either got chickenpox from the vaccine or they caught chickenpox from another child, but they had a very mild case. Either way, that's how this virus works. You receive some of the live virus and you may have some fever, you may get a few pox, but it is very mild compared to full-blown um, varicella. The reason we care, it's not just because it's an itchy nuisance, but immunosuppressed children, adults, pregnant women, varicella can cause some major complications. In children, not only can you have bacterial infections of the skin and soft tissues, but you can also develop pneumonia and encephalitis. Those at high risk for severe complications are newborns whose mothers had varicella. They had chickenpox 2 to 5 days before they gave birth. So, a pregnant mom that's about ready to deliver that contracts chickenpox um, is at that baby is at high risk for having a complication. Premature babies who are exposed, and the pregnant woman in general. Pregnant women who catch varicella are at risk for serious complications, primarily pneumonia. And in some cases, they actually have died as a result of chickenpox. Some studies have suggested that both the frequency and the severity of pneumonia are higher when varicella is acquired during the third trimester, but that hasn't been proven yet. It's just being suggested. If a pregnant woman gets varicella in her first or second trimester, her baby has a small risk, like up to 2% risk of being born with congenital varicella syndrome, which results in scarring on the skin, abnormalities or birth defects of the extremities. The brain can have some brain damage, some damage to the eyes, possibly low birth weight. But like we said, if the mom develops the varicella rash from 5 to 2 days, 5 days before delivery to 2 days after delivery, the newborn will be at risk for neonatal varicella. Historically, the mortality rate for neonatal varicella was about 30%. But now we have a varicella zoster immune globulin, and the ICU that has reduced that mortality in neonates to about 7%, but still that's 7 out of 100 babies that would die as a result of chickenpox. And in case you were wondering, the vaccine is contraindicated for pregnant women, and that ought to make sense to you since we know that the vaccine is live and you can have some symptoms of chickenpox when you are vaccinated. So nursing interventions, just basic Tylenol for the fever, calamine lotion, Benadryl for the itching, keeping fingernails, short. But here, the main thing on this slide that I want to show you is that we have different stages of the blisters. We have when they're just papules, when they actually blister, and then they burst and ulcerate and crust over. So everything has to be crusted over and no new lesions for 24 hours before we can say a child is no longer contagious. Rye syndrome. You need to understand about Rye syndrome. Rye syndrome came about in the late 70s, early 80s is when we started to recognize it. Actually, it was first described in the 60s. But Rye syndrome is characterized by acute, non inflammatory encephalopathy. So you have acute swelling of the brain, but there is no inflammation. And with that, we have fatty liver failure. So all of a sudden, the child will develop a fatty liver and go into acute liver failure. So, swelling of the brain with no inflammatory process going on, no infection, no signs of inflammation, and liver failure, fatty liver failure. This was first described in 1963, but they think that cases were actually identified as early as 1929. It peaked in our country around 1979 to 1980. And they started to notice that this mystery illness tended to correlate with flu season. Um, Rye syndrome typically occurs after a viral illness, particularly an upper respiratory tract infection, like the flu, varicella, or a gastroenteritis. And it is associated with the use of aspirin during that viral illness. It can also occur after a vaccine. So, if you get the chickenpox vaccine, you should avoid aspirin products for about 6 weeks after that. So, when they started to study this mystery illness where children were coming in with elevated ammonia levels from liver failure, they acted as if they'd had a head injury or meningitis, that maybe they were having seizures. We'd rush them to CT and their brain is swelling, and we're trying to figure out what in the world is going on with these kids. And eventually, the smart people out there put two and two together that what these kids historically had in common was a recent illness, viral illness, usually respiratory viral illness, and they had all received aspirin in the course of that illness. So yes, it correlated with chickenpox and it correlated with flu season. So these kids had fatty changes in their liver and edematous encephalopathy following aspirin use. This would be like 3 to 5 days later after aspirin use following a viral illness. Usually we saw it in kids 6 months to 15 years old, preceded by this viral illness, managed with normal levels of aspirin. They weren't toxic. And the kids ended up vomiting, irritable, lethargy. We could palpate their liver. You shouldn't be able to palpate the liver. 25% of those children will progress to coma. And like before we even know what's happening, they die or they have permanent brain damage. So when we started to put two and two together, and the FDA came out and said, hey, no more aspirin for kids. A dramatic decrease in the use of aspirin among children in combination with the identification of some different things like uh, medication reactions, some toxins, some other things that present with Reye syndrome like manifestations have made the diagnosis of Reye syndrome exceedingly rare now because we have decreased the use of aspirin among children and we've identified some other well, don't even worry about that part because we're not getting into all that. But there's some other very unusual disorders that have to do with inborn errors of metabolism and things like that. But don't worry about that. With the recognition that Reye syndrome is rare, this condition should be considered in the differential diagnosis in any child that presents with vomiting, altered mental status, and classic laboratory findings. No infection. They don't have signs of a bacterial infection. They don't have evidence in their CSF of meningitis, yet their CT shows edematous encephalopathy. A high index of suspicion is essential because we don't see Reye syndrome very often, and vomiting, irritability, lethargy, that's not unique to Reye syndrome. That could be, there could be many causes of that. So we can't forget to have Reye syndrome in the back of our mind. I think about the child who spent the weekend at grandma's house and developed a fever, has a flu-like illness. Grandma doesn't have children's Tylenol laying around, but you know what? She does have a baby aspirin. So why couldn't it still happen today? It could. So there is no specific test for Reye syndrome. It is a diagnosis of exclusion. And, in the past, unfortunately, many of the diagnoses were made post-mortem. Early recognition and treatment is essential to prevent death and optimize the likelihood of recovery without neurologic impairment. So, let's see. Whoop, sorry about that. So basically, children less than 19 should not take aspirin containing products. And you can look at the Surgeon General website, the FDA, the CDC, the American Academy of Pediatrics, the WHO. Everybody agrees it is not worth the risk. And children less than 19 should avoid aspirin containing products. So, basically just remember there are two things that we see with Reye syndrome: fatty accumulation in the liver, in the hepatocytes, and loss of neurons in the brain, edema, and fatty degeneration of the kidneys. So in the brain, we have loss of neurons and a lot of edema, just like water. There's no infectious agent. The liver fat just starts to accumulate quickly in the liver and cause liver failure. We maybe the liver dysfunction, the high ammonia that occurs as a result of the liver dysfunction may lead to the edema in the brain. We don't really know. And then here's another slide just kind of reinforcing diagnostic criteria for Reye syndrome: acute non-inflammatory encephalopathy, altered LOC, hepatic dysfunction showing fatty metamorphosis. You have elevated ALTs and ASTs, possibly ammonia levels. No other explanation for the cerebral edema or the liver failure. CSF has not hardly any white blood cells, so there's no signs of infection. And ultimately, the brain biopsy shows the cerebral edema without inflammation. Less than 0.1% of children who took aspirin developed Reye syndrome, but okay, so what I just said was less than 0.1% of children who took aspirin developed Reye syndrome, but more than 80% of patients diagnosed with Reye syndrome had taken aspirin in the past 3 weeks. So it is a causal relationship that has not been 100% definitively established, but based on the likelihood that it is related to aspirin and the dramatic decrease in the incidence of Reye syndrome when we stopped giving aspirin to kids, it is recommended. Um, the mortality rate has also decreased from 50% to less than 20% because now we know how to recognize it early, diagnose it, hopefully recognize it when it's just a mild case, and institute aggressive therapy. So, talking about the flu, a new CDC study published in Pediatrics is the first of its kind to show that flu vaccination significantly reduced a child's risk of dying from influenza. The study, which looked at data from 4 flu seasons between 2010 and 2014, found that flu vaccination reduced the risk of flu associated death by half among children with underlying high risk medical conditions, and it reduced the risk by nearly 2/3 among healthy children. So, this study really underscores the importance of following the CDC recommendation and the AAP recommendations that all children 6 months and older get a flu vaccine. In 2019, the CDC put out in their September newsletter an article that reads, this is the title: CDC study finds the number of babies hospitalized with the flu is at least double previous estimates. So that was a multi-country CDC study, and it found that the number of children younger than 1 who were hospitalized with the flu is at least double the previous estimates. So that was last fall. And that is very concerning. So these are babies that are hospitalized with the flu. And knowing, I don't know what ages, these are just kids that are younger than 1, but knowing that children 6 months and older can get a vaccine. And if they do, it reduces the chance by half to 2/3 that they will get sick. It really drives home the point that these kids need to get vaccinated. There's been question in the past about allergies to eggs. If the child is allergic to eggs, it is between the doctor and the parent whether or not that child gets vaccinated. I think it's really more with the live flu vaccine than the vaccine that we have today. Main point here is 6 months of age. Do not vaccinate for the flu if they are less than 6 months of age. Okay. Babies and other children receiving the flu vaccine for the first time need 2 doses. Babies younger than 6 months who are too young to be vaccinated themselves, this most recent study emphasizes the importance of flu vaccination during pregnancy because the mom can help protect her baby during those first couple of months of life when the baby's not old enough to have the flu vaccine. So we said that for the chickenpox or Varivax vaccine, they had to be 1 year of age. For the flu vaccine, they have to be 6 months old. And then I think this is the last thing I want to talk to you guys about, and it is Mycoplasma pneumoniae. And we've talked about it a lot in clinical, but you need to know this. Mycoplasma is a small atypical bacterium, and there is no vaccine for this. This is just one of those off the wall things that I don't think I covered it in respiratory in detail, so I just wanted to hit it again. Mycoplasma, it acts like a virus. So for years, they thought it was a virus because it did not stain under the microscope. Mycoplasma lacks a rigid cell wall, and that cell wall is what stains when we look at something under a microscope. So we couldn't see it. They thought it was a virus, but eventually we figured out that, hey, this responds to antibiotics. And I'll tell you the story about that in a minute. But it's a major cause of illness in children and adolescents. It causes fever, sore throat, cough, malaise, headache, abdominal pain. We've seen that a lot. It can cause pneumonia. Sometimes it's just these symptoms, but it can go on and cause pneumonia. Pneumonia caused by Mycoplasma pneumoniae is a type of atypical bacterial pneumonia because it does not respond to sulfa drugs or penicillin. Experts estimate that Mycoplasma pneumoniae infections account for between 1 and 10 in every 50 case in 1 to 10 of every 50 cases of community acquired pneumonia. So when you hear a physician treating a child for, you know, a run-of-the-mill community acquired pneumonia, you're going to see that they're going to cover them with a gram-negative antibiotic like your Rocephin, and they're going to cover them with Zithromax because most likely, if it's community acquired, it's Mycoplasma pneumoniae. Mycoplasma was first isolated from the sputum of a patient with primary atypical pneumonia in 1944. So remember when we looked at the x-rays of the different kinds of pneumonia? So here we have a patient that's just sick, 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 wheezing, 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 but the x-ray doesn't look that bad. The labs don't look that bad. I mean, the white count might be 10 or 11, maybe 12. So they had this atypical pneumonia. Scientists thought that the bacterium was a virus until they observed that antibiotics could be effective against it. So the cell volume of Mycoplasma is less than 5% of the cell volume of a typical bacillus. So that means it's really small. That small cellular mass means that it can pass through filters that are typically used to remove bacteria. So Mycoplasma being so small can really get in there and infect a person easier than a regular sized bacterium. Light microscopy cannot detect it. So under the microscope, it cannot be detected. It does not produce visible turbidity in liquid growth media. And in order to get a visual confirmation of growth, we have to use a special media. So, a lot of this goes back to the fact that it lacks that rigid cell wall. And because it doesn't have a rigid cell wall, it can actually alter its size and shape to squeeze in wherever it needs to get. It's intrinsically resistant to antibiotics like beta lactams, which would be like your Zosyn. Um, it Due to the lack of a cell wall, it is extremely susceptible to um, desiccation. Thus, bacterial transmission from person to person by airborne droplets only occurs through close contact. So, so all that stuff about not having a cell wall is really good once it's inside your body and it can squeeze through and get where it wants to go. But if I were to cough up some mycoplasma, it doesn't last long because it doesn't have that cell wall. It just kind of desiccates, it falls apart. So to transmit mycoplasma from me to you, we have to have close contact. So you see siblings share this sort of thing. Okay. So most common in school-age children, 5 to 15. Frequently seen in the late summer, early fall. We used to call this our summer pneumonia, but now we pretty much see it year round. And Zithromax is our drug of choice. Zithromax, Zithromax, Zithromax for children and adults. There are other drugs that can be used, but the safest drug and the one recommended for children is Zithromax. These kids can have runny nose, wheezing, with or without fever, sometimes diarrhea and vomiting. Oftentimes, surgeons admit these kids thinking they have appendicitis and they've learned to just run a mycoplasma test when things aren't 100% clear. And oftentimes, mycoplasma is the cause of their abdominal pain. So complications, our asthmatic patients, they get admitted in the hospital with mycoplasma. This is a bacteria that can just cause what they call walking pneumonia in healthy people, but people with underlying illness can have some pretty severe complications. Um, as you can see here, the main thing is the severe pneumonia and exacerbation of asthma. These the GI complaints, of course, I've seen that, but the other things are unusual, but they could happen. Okay, I'm not going to have MRSA on the test. There's some pretty pictures here and stories for you to read. And I mentioned the drug Teflaro, which is a great new antibiotic that has been approved in pediatric patients and adult patients for acute bacterial skin infections. And the great thing is it can cover gram negative and gram positives. So it's a really cool drug. It can cover E. coli and it can cover MRSA. It's a really cool drug that we use sometimes on peds now. So and then I love this slide. The best interest of the patient is the only interest to be considered. And in order that the sick may benefit of advancing knowledge, union of forces is necessary. That doesn't mean unite and cheat on my test, just in case you were wondering. All right, I'm going to go help you out and post something to help you focus your studying. And good luck, everybody. See you later. Bye.